Hello, it's Dmitry again. We're going to be doing another chapter today from the Mehlman Medical PDF for Internal Medicine. Today we'll be doing the Internal Medicine Immunology chapter. Again, like the video we had earlier today, this is going to be one of the shorter chapters and it should be able to fit into a single video. I believe this chapter is only about 6 pages or something like that, so it shouldn't be that crazy. So, Internal Medicine Immunology. Immunodeficiencies, high yield points for IK. Or I assume they meant IM, but because, whatever, M and K are right next to each other on the keyboard, but whatever, who knows. 2CK is known to ask immunodeficiency mechanism questions at step 1 level detail. Really? Okay. Severe combined immunodeficiency, SCID. X-linked recessive, most common, usually due to common gamma chain mutation or mutation in IL-2 receptor. Autosomal recessive type less common due to deficiency in adenosine deaminase, ADA. Combined T and B cell deficiency. T cell deficiency means absent thymic shadow. B cell deficiency means scanty/absent lymph nodes and tonsils. Question will give you a sick kid who's had infections of all different types, that is to say, viral, fungal, bacterial, protozoal since birth. This contrasts with Bruton XLA, Bruton's disease. What does XLA stand for in this case? Seems like it already off the stop a little bit of a detour, but Bruton XLA. Bruton X-linked agammaglobulinemia. Okay. Should have known. What am I doing? So this contrasts with Bruton's X-linked agammaglobulinemia, which will be just bacterial infections, usually since 6 months of age. Treatment would be bone marrow transplant. Oh, it's right there. I'm sorry. Bruton X-linked agammaglobulinemia. X-linked recessive. I do this all the time. I'm like, what is this thing? What's this acronym for? And then I wait 5 seconds later, I know what it is. It's right there. Or something like that. Or I'm talking about a subject matter, like how this relates to this other topic, and they talk about that topic 5 seconds later because it's obviously relevant. Bruton X-linked agammaglobulinemia, or XLA. X-linked recessive, as name implies, caused by mutation in Bruton tyrosine kinase, isolated B-cell deficiency, scanty/absent lymph nodes plus tonsils. Kid will have a decrease in immunoglobulins of all classes because B cells make antibodies. Question will almost always be a boy who's had only a bacterial infection since 6 months of age. If they mention bacterial and viral, fungal, and or protozoal, the diagnosis is going to be SCID. Again, that's severe combined immunodeficiency. There is a question on the 2CK form where they say bacterial infection since birth, but you're able to eliminate the other answers. Literally 14 out of 15 questions will say from 5 to 7 months onward. So this is highly annoying to have to make, but I have to communicate it's because it's on the NBME. Treatment on NBME is monthly infusion of immunoglobulin. Answer on USMLE will often be a deficiency of humoral immunity rather than just Bruton XLA. So they're a little bit more roundabout, again, as you typically see in these exams. It might be a little bit roundabout about how the answer is going to be characterized. Deficiency of humoral immunity. IgA deficiency. One of the highest due conditions for the step, hence why I mentioned it repeatedly in this document, purposeful redundancy. Most common hereditary immunodeficiency. 9 out of 10 questions will give you recurrent sinopulmonary infections in someone between the high school and their 30s. 2CK question has it in a kid. The question might say the patient has a sore cheek, sinusitis, plus a history of pneumonia. Anaphylaxis with transfusion of blood products is a ultra-high yield detail, but often omitted from real NBME questions because it's too easy/buzzy. They don't want to give the answer away. Atopy is really high yield, asthma, seasonal allergies, eczema, history of Giardia infection, associated with other autoimmune diseases like vitiligo or celiac disease. Celiac antibodies screen falsely negative in IgA deficiency. Interesting. IgA deficiency can be associated with false positive pregnancy tests. Yes, weird, but due to heterophile antibody production apparently with zero relation to Epstein-Barr virus. Answer on USMLE will often be deficiency of mucosal immunoglobulin or deficiency of humoral immunity rather than just IgA deficiency. Again, they're not going to straight up tell you what it's going to be. They're going to get this sort of roundabout answer of deficiency of mucosal immunoglobulin. You're supposed to know what that is, right? Deficiency of humoral immunity, again, super non-specific, right? Because what we said here about Bruton's XLA, that's also sometimes just called deficiency of humoral immunity. Apparently, IgA deficiency is also sometimes called deficiency of humoral immunity. So, in a certain sense, it's more broad, but it also means that it's not super clear as what they're talking about, So, when you're looking for an answer, just be aware of that. The George syndrome, T-cell deficiency caused by the 22q11 deletion, failure of the development of the third and fourth pharyngeal pouches, not the arches, the pouches, leading to a third becoming the thymus plus the two inferior parathyroids. These structures form a triangle. Third, right? Fourth becomes two superior parathyroids. Okay. So the third becomes the thymus plus two inferior parathyroids, while the fourth becomes the two superior parathyroids. So in the George syndrome, that doesn't develop correctly. And so as a consequence, you have an absent thymic shadow, you have hypocalcemia due to the hypoparathyroidism, positive Schwastek and Trousseau signs of hypocalcemia, tetralogy of Fallot, VSD, overriding aorta, pulmonic stenosis, RVH, and truncus arteriosus are high-yield cardiac anomalies. Cleft lip/palate may or may not be mentioned. Patient will have normal antibody levels even though the T cells activate B cells. Choose normal antibody levels. So if they ask you, if you know the patient has DeGeorge syndrome, right? They have the hypocalcemia, they have hypothyroidism, they have all these other issues, but they ask you, do they have normal antibody levels? The answer is yes. Yes. It's weird, but technically they do. Chronic mucocutaneous candidiasis, T-cell dysfunction, recurrent candidal skin infection since birth, choose deficiency of cell-mediated immunity, associated with other autoimmune diseases, for example, type 1 diabetes mellitus, thyroiditis, 17-year-old female, recurrent candidal skin infection since birth, plus 1 year history of autoimmune thyroiditis, plus 2 year history of type 1 diabetes. Mechanism for infections, the answer should be deficiency of cell-mediated immunity. Again, super not specific. Chronic mucocutaneous candidiasis, oh, well, probably deficiency of cell-mediated immunity. It's like, okay, sure. But they're not being very specific to what's going on. It's a T-cell dysfunction. NAD, and maybe they are going to be more specific, but sometimes they're not going to be. Sometimes they're going to be a little bit vague, NADPH oxidase deficiency, aka chronic granulomatous disease, CGD, usually X-linked recessive. First enzyme of the respiratory burst converts molecular O2 into superoxide. Recurrent infections of catalase-positive organisms, Serratia, Pseudomonas, Aspergillus, Candida, E. coli, Staph, and H. pylori. Condition that results in a decreased ability of the patient to synthesize enough H2O2, which is I think a superoxide, to overwhelm the catalase-positive organisms. Diagnosed with dihydrorhodamine test, tetrazolium blue assay is the atavistic and the wrong answer if both are listed as per NBME. So you go for the dihydrorhodamine test. Now, but don't go for the tetrazolium blue assay if both of them are listed. Go for dihydrorhodamine if both of them are listed. Dihydrorhodamine test is what you want to go for. Now, here's the thing. I'm not going to go too specific with it. I want to confirm. What is H2O2 superoxide? I'm sorry, but I'm not a chemist. Hydrogen peroxide. Now, there's different things that exist. There's bleach. That's like HCOL, right? There's superoxide, and there's hydrogen peroxide. But all these are part of the general mechanism that the body uses to kill these bacteria when they get into the when they're phagocytosed. They're phagocytosed, and then they have like a lysozyme that destroys them by releasing. Fundamentally, it's going to be HCOL, so bleach. But the antecedents to bleach are going to be hydrogen peroxide, and before that, superoxide, I believe. So that's kind of what's going on with that. And if that system does not work correctly, because even NADPH oxidase deficiency, well, then you aren't going to be able. Well, then it's going to be more difficult to create these sorts of reactive oxygen species. But the body can, in theory, basically use some of the reactive oxygen species from like bacteria and stuff like that, which make their own. Except the ones with the what do you call them? They have the name right here, right? Catalase positive organisms. Catalase prevents the body from being able to use these bacterial reactive oxygen species. I think specifically one of them, I forget which one it was. I think it might be superoxide. Does it say that? It might be that. Yeah, I think it might be that. And as a consequence of that, don't quote me on that one, but as a consequence of that, it won't be able to weaponize that against the bacteria itself. And in that context, it dies, right? The bacteria proliferates because it can't be actively dealt with in the way that you would if you actually had normal NADPH oxidase to make these reactive oxygen species, fundamentally being the final product of bleach, which is very dangerous to these bacteria. What does catalase do? It breaks down, so catalase is a vital antioxidant enzyme that speeds up the breakdown of toxic hydrogen peroxide. Yep, okay. So it breaks down hydrogen peroxide. So your body won't be able to weaponize hydrogen peroxide made by bacteria against the bacteria themselves because, again, they're being broken down before the body can access it effectively. And so you can get these organisms that have catalase, or catalase positive, like Serratia, Pseudomonas, Aspergillus, Candida, E. coli, Staph, and H. pylori, can run roughshod, basically, against you if they have the opportunity to. If you have CGD. And the thing is, you do form these granulomas where the body says, we can't kill these bacteria. We're going to create, like, basically a walled off area, which is what a granuloma basically is going to be, this sort of containment zone to prevent the infection from getting any bigger. What about myeloperoxidase deficiency? Myeloperoxidase deficiency, autosomal recessive, last enzyme in the respiratory burst, converts the hydrogen peroxide into hydroxyl halide radicals, which are bleach. Question will literally give you a one-liner telling you someone can't produce hydroxyl halide radicals, and the answer is myeloperoxidase deficiency. Question can mention myeloperoxidase deficiency in vignette, and then the answer is impaired conversion of hydrogen peroxide to hypochlorous acid. Usually presents as a mix of Staph aureus and Candida infections. Question on the free 120 gives you mix of Staph aureus and Candida infections in a 6-year-old girl with autosomal recessive disorder. Question wants MPO deficiency as the answer, not CGD. Even though CGD can present with the same organisms, the literature not only says that 70% of CGD cases are X recessive, but if the CGD occurs in children, it usually is X recessive. Since less frequent autosomal recessive CGD is more often mild and presents later. So this is worse. MPO is worse. MPO deficiency is worse. Wiskott-Aldrich syndrome, X-linked recessive WAS gene, T-cell cytoskeletal dysfunction, triad of immunodeficiency, eczematoid skin lesions, thrombocytopenia, elevated serum IgA/IgE, decreased IgM, 12M plus pneumocystis infection plus history of nosebleeds and eczema. Question asks, what is the cells dysfunctional? The answer should be T cells are dysfunctional for Wiskott-Aldrich syndrome. The answer can be deficiency of cell-mediated immunity. Again, super, super, super not specific, but sure. Leukocyte adhesion deficiency. Deficiency of CD18/LFA1 integrin. Decreased ability of leukocytes to leave the blood vessels to the sites of infection, leading to a decrease in pus. Classically associated with delayed separation of umbilical cord. Answer can be defective leukocyte chemotaxis instead of just LAD. Again, they're not going to be super direct with you sometimes. Chidiac-Higashi syndrome. Phagolysosome fusion disorder with disruption of microtubule function. Melanosome function also impaired, leading to partial albinism/fairer skin than siblings. Giant granules and phagocytes in neutrophils and eosinophils. Ataxia-telangiectasia. Failure of double-stranded DNA break repair. Cerebellar atrophy leading to ataxia. Telangiectasias. Increased susceptibility to radiation leading to an elevated risk of leukemia and lymphoma. Hyper-IgM syndrome, deficiency of the CD40 ligand on CD4 positive T cells. Decreased activation of CD40 on B cells, leading to a decrease in B cell activation, leading to a decrease in the ability to differentiate into plasma B cells, plus isotype class switch, leading to an antibody isotype stuck at IgM. Hyper-IgE syndrome, or Job syndrome. Faded, this is a little acronym for you, abnormal facies, staphylococcal cold abscesses, retained primary teeth, hyper-IgE, dermatologic findings, eczematoid lesions. So that's hyper-IgE syndrome. IL-12 receptor deficiency. Recurrent TB infections. Important point for USMLE is that the Th1 CD4 positive T cells and macrophages activate each other in a cyclical loop via the IL-12 and interferon gamma. Th1 cell lacking the IL-12 receptor cannot get activated and therefore does not secrete interferon gamma, leading to macrophages not activated, therefore a decrease in granuloma formation. Common variable immunodeficiency, or CVID. Normal B cell number but defective maturation into plasma cells, decreased immunoglobulin production, will be the answer, and if the question gives you an adult who has a recurrent sinopulmonary infection similar to IgA deficiency, except a decrease in Ig, not limited to the IgA. Okay, so there's a decrease in immunoglobulin, not just IgA specifically. In addition, if vignette gives you an atopy of Giardia, the answer is IgA deficiency, not CVID. If they talk about atopy of Giardia. Okay. Terminal complement deficiency. Deficiency of the C5 through C9 complement proteins cannot form the membrane attack complex MAC. Recurrent Neisseria infections, both gonococcal, so Neisseria gonorrhea, and meningococcal, i.e. Neisseria, Neisseria meningitis, I believe? Yeah. Question will often have deficiency of C7 or C8 as the answer. That is to say, they choose a random terminal complement protein or terminal complement deficiency or complement-mediated immunodeficiency. Where are we with this? We're pretty close to done, I believe. Yeah. Oh, well, that's okay. So let's continue. High-yield autoantibodies for USMLE. So here's the high-yield disease association, and here's the high-yield antibody. Antibodies. So a lot of different things. Okay, so antiphospholipid syndrome. What do you have associated with that? The antibodies? Anti-beta-2 microglobulin, anticardiolipin, lupus anticoagulant. The latter is the name of either of the former two if the patient happens to have lupus. Antibodies associated with the recurrent miscarriage can cause false positive syphilis screening. That is to say, SLE lupus patient who gets positive syphilis VDRL test. Bullous pemphigoid, anti-hemidesmosome bullous pemphigoid antigen. Hemidesmosomes connect the dermis to the epidermis, causes a linear immunofluorescence on skin biopsy. Pemphigus vulgaris, antidesmosome, antidesmoglein 1 and 3. Desmosomes connect the adjacent cells in the epidermis, causing a net-like immunofluorescence on skin biopsy. Goodpasture syndrome, anti-collagen 4, Is that anti-glomerular basement membrane? Glomerular basement membrane, yeah, okay, thank you. Causes linear immunofluorescence on renal biopsy. Don't confuse with Alport syndrome, which is mutations in the type 4 collagen, not antibody. Granulomatosis of polyangiitis, or Wegener. C-ANCA, antiproteinase 3, PR3, dumb mnemonic I created that helps some of my students. Water closet, Wegener C-ANCA. Okay. Eosinophilic granulomatosis of polyangiitis, or Church-Strauss syndrome. P-ANCA, anti-myeloperoxidase. Microscopic polyangiitis, P-ANCA, anti-myeloperoxidase. Systemic lupus erythematosus, or lupus, standard lupus. When we hear lupus, we usually think about SLE. Anti-double-stranded DNA, dsDNA, anti-Smith ribonucleoprotein, and anti-hematologic cell line antibodies. Should be noted that the dsDNA, or double-stranded DNA, goes up in acute flares, plus best reflects renal prognosis. Anti-Smith is more specific than anti-dsDNA. However, thrombocytopenia is an exceedingly high yield finding in lupus due to antibodies. If all cell lines are down in lupus, aplastic anemia or decreased bone marrow production is the wrong answer. Choose increased peripheral destruction as the answer. Drug-induced lupus. Antihistone caused by various drugs. Mom is HIP, minocycline, hydralazine, INH, procainamide, penicillamine. Myasthenia gravis, anti-postsynaptic acetylcholine receptor, sometimes a paraneoplastic of thymoma. Lambert-Eaton syndrome, anti-presynaptic voltage-gated calcium channel, sometimes a paraneoplastic of small cell lung cancer. Small cell cerebellar dysfunction, anti-WHO/YO, ataxia, in someone with a small cell lung cancer and negative CNS imaging. Polymyositis/dermatomyositis, anti-JO1, can be paraneoplastic of ovarian cancer. Limited type systemic sclerosis or scleroderma, anti-centromere. Diffuse type systemic sclerosis/scleroderma, anti-topoisomerase 1, SCL70. Primary biliary cirrhosis, antimitochondrial. Autoimmune hepatitis, anti-smooth muscle. Rheumatoid arthritis, rheumatoid factor, and IgM against the Fc region of the IgG, anticyclic citrullonated peptide, CCP, and anti-CCP is more specific than rheumatoid factor. Sjogren's syndrome, anti-SSA, anti-Rho, anti-SSB, anti-LA, or LA. No, LA, anti-Rho, anti-LA, what have you. Graves' disease, anti-TSH receptor. This is antibody is called the thyroid stimulating immunoglobulin, or TSI, and activates the TSH receptor, which is why you have to have hyperthyroidism in that context. Hashimoto thyroiditis, anti-thyroperoxidase, anti-microsomal, anti-thyroglobulin. Thyroperoxidase is also called TPO. So, yeah. Pernicious anemia, anti-parietal cell, anti-intrinsic factor. Celiac disease, anti-endomysial, aka anti-gliadin, anti-tissue transglutaminase, IgA. Antibody screening will yield false negatives if patient also has an IgA deficiency. Type 1 diabetes mellitus, anti-glutamic acid decarboxylase, or anti-GAD, anti-zinc transporter 8. Primary membranous glomerulonephritis, anti-phospholipase A2 receptor. Thrombotic thrombocytopenic purpura, anti-ADAMS TS13, a matrix metalloproteinase that cleaves the von Willebrand factor multimers. Immune thrombocytopenic purpura, aka idiopathic thrombocytopenic purpura. Anti-GP2B/3A on platelets, platelet aggregation. Heparin-induced thrombocytopenia, anti-platelet factor 4 heparin complex, anti-PF4 heparin. Addison's disease, anti-21 hydroxylase. Rheumatic heart disease, anti-myosin, anti-valve-derived proteins. Should be noted that the antibodies are formed against strep pyogenes, M protein, and almost always cross-react with the mitral valve molecular mimicry. Neuromyelitis optica, Devic syndrome, anti-aquaporin 4, Aston 2-CK form. Cold autoimmune hemolytic anemia, IgM against RBCs, CMV, and mycoplasma are high-yield infectious associations will result in positive Coombs test. Warm autoimmune hemolytic anemia, IgG against RBCs, various miscellaneous drugs and infections also associated with chronic lymphocytic leukemia will result in positive Coombs test. And that is the end of our immunology chapter. It was only less than 25 minutes. It was 23 minutes and some seconds. It wasn't an hour, it was not even half an hour. Very short chapter. Well, if you enjoyed that chapter, as I'm sure everybody listening to this loves, studying medicine, I can imagine. So if you love that chapter, if you absolutely just thought it was the most amazing thing possible, just like and subscribe, I guess. I don't know. Otherwise, hopefully it was of good use to you regardless. Have a great rest of your day. Thank you, and goodbye.